Hello everyone, today I shall be speaking on comparison of ultrasound and MRI in imaging of pediatric spine. I have no disclosures. Ultrasound of the pediatric spine is a first modality of imaging when we are evaluating neonates and young adults for spine, mainly because it is safe, accessible, cost-effective, and lacks radiation, and any images that are detected on ultrasound can be followed on MRI for further characterization. This is a list of indications enlisted by the American Institute of Ultrasound in Medicine as recent as 2021, and as we see, the most common indication is cutaneous stigmata as delineated in the right-sided table, which are known to be associated with spinal dysraphism as asymmetric gluteal cleft, dorsal dermal sinuses. There are other indications. It also acts as a guiding tool for lumbar puncture, and ultrasound is also required when assessment of cord is to be made for abnormalities as tethering or diastematomyelia. Technique is very important in ultrasound. It is warranted that high frequency linear transducers be used to perform the ultrasound, and cord must be assessed in transverse and longitudinal planes. Additional views as extended field of views and images and M mode might be helpful. When MRI is performed, typically a slide thickness of 3 to 4 mm, and most commonly acquired sequences are SAG T1, T2, and STIR, and axial T1 and T2. In vertebral curvature anomalies, coronal sequences can be added. Typically, contrast is not needed in evaluation of pediatric spine. Now let us review at some case-based examples to further illustrate the role of each modality. This is a newborn who presented with imperforate anus, and we have ultrasound images. What is the diagnosis? The patient had, as seen on this ultrasound, low conus, tethered cord, and spinal lipoma, which is demonstrated very well in this corresponding MR images. SAG T1 and T2 sequences demonstrating hyperintense lesion consistent with spinal lipoma. The patient's radiograph demonstrated dysmorphic sacrum consistent with Caudal Regression Syndrome. The next case was of a newborn with sacral dimple, and we have an ultrasound image with a corresponding axial T2 MR image. What is the diagnosis? And this was a case of diastematomyelia, as demonstrated well in these ultrasound and MR images, where we see hemichords, and an ultrasound the intervening septum is well evident. The next case demonstrated on ultrasound a cystic structure in the proximum phylum, and it was consistent with anatomic variant of Filar cyst. Interestingly, the corresponding images did not show the lesion very well, mainly because of the surrounding CSF. This case also highlights the point that in ultrasound, a decision can be made by us whether or not a further follow-up MR is warranted. The next case was of a neonate who presented with fever. And what is the diagnosis? We have ultrasound and color Doppler images. The following MRI images also demonstrated the lesion, which on ultrasound was cystic and demonstrated peripheral flow, and on MRI demonstrated peripheral rim enhancement. The FNG images demonstrated diffusion restriction in the center, consistent with the diagnosis of infected pilonidal cyst. Sinus. To conclude, ultrasound pediatric spine has the advantage of being a primary modality of imaging, but it comes with the limitation of suboptimal soft tissue resolution for deeper structures. And MRI has a distinct advantage of being a multiplanar capability with excellent soft tissue resolution, but does come with limitations for need for sedation and longer acquisition times with motion artifacts. These are my references. Thank you.